We're going to call the meeting to order. Rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay. Welcome, everyone. Dee, would you please take the roll?
Director Wallace.
Present.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Eapen.
Present.
Director Danielson.
Okay, that motion passes. I mean, that's not a motion, that's just a roll. Okay, we're going to take up resolution number 1191.
Mr. President, it's my honor to move for adoption of resolution number 1191, which is the resolution of the Board of Directors of Washington Township Healthcare District acknowledging the appointment of Michael Wallace, Bernard Stewart, and Jacob Eapen as directors of the Board of Directors of Washington Township Healthcare District.
Yeah. Thank you for that motion. Do we have a second?
Second.
Okay. All those in favor? Sorry. Dee, please do the vote.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Eapen.
Aye.
Director Danielson.
Okay, that motion passes. All right, at this point of time, we're going to have the oath of office.
And
Nancy?
I'd like to introduce to the board and our audience, Judge Thomas Nixon. Judge Thomas Nixon is the supervising judge for the Superior Court of California, County of Alameda County's Family Law Division. Judge Nixon was appointed to the Superior Court in 2015 by Governor Jerry Brown and has served as a commissioner at the Alameda County Superior Court since 2002. He was an attorney in private practice from 1998 to 2002, a partner at Quaresma, Benya, Hall, Conich, O'Hara, and Nixon from 1989 to 1998, and an associate at Quaresma, Benya, Hall, and Hahn from 1984 to 1989. Judge Nixon earned a Juris Doctor degree from the Santa Clara University School of Law and a Bachelor of Science degree from San Jose State University. With that, I'd like to ask Judge Nixon to come forward and begin the process of swearing in.
I will. Start with Mr. Wallace.
Yep. Fellow Santa Clara graduate.
And our pass rate is still good. I hate when they go over all that stuff because it makes me realize just how old I've become. Raise your right hand. Repeat after me. I, Michael Wallace,
I, Michael Wallace,
solemnly swear
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United
the
States
Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
that I will bear true faith
that I will bear true faith
and allegiance
and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California.
and the Constitution of the State of California,
That I take this obligation freely,
that I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties
discharge the duties
upon which I am about to enter.
upon which I am about to enter.
Thank you. Next victim.
Yes.
Please raise your right hand and repeat after me. I, Bernard Stewart,
I, Bernard Stewart,
solemnly swear
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
that I will bear true faith
that I will bear true
true faith
and allegiance
and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties
discharge the duties
upon which I am about to enter.
upon which I am about to enter.
Congratulations, Doctor.
Thank you.
And finally, Dr. Please raise your right hand. Repeat after me. I, Jacob Ippen,
I, Jacob Epen,
solemnly swear
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
that I will bear true faith
that I will bear true faith
and allegiance
and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and to the Constitution of the State of California.
that I take this obligation freely
And I take this obligation freely,
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties
discharge the duties
upon which I am about to enter.
upon which I am about to enter.
Congratulations.
Thanks.
Do you want me to execute these now? Or later?
We'll do them later on.
Very good.
I think that following the oath of office, we were going to take a short break.
Okay,
Dean has arranged for some sparkling cider.
okay, we're going to now take a short break. Thank you. Okay, we're going to reconvene and go to the election of officers. So,
Mr. President, I'd like to move for a slate of officers for the 2018-2019 year. For President, Bernard Stewart. First Vice President, William Nicholson. Second Vice President, Patricia Danielson. Treasurer, Jacob Epen. Secretary, Michael Wallace.
thank you. Do we have a second, Pat?
Dr. Epen.
No, we have a second? Okay.
Yeah.
Dee?
Director Wallace,
Aye?
Director Stewart,
Aye.
Director
Not
Nicholson.
sure.
Director
boy.
Nicholson,
Aye.
Director Epen,
Aye.
Director Danielson.
That sounded like the response to Tag, you're it.
Okay, well, that motion passes, and we're going to change seats.
There we go.
Okay. Yeah, you're not going to get my sandwich. Okay.
Thank you very much. It's nice to begin a new year and a new time here on the board. It's good to be together. We'd like now to move to our educational session. If Nancy, if you could introduce that for us.
I'd like to tee this one up. You're going to be participating in a mandatory requirement for board members, and it is in response to Assembly Bill 1234, and it requires elected officials to have ethics training. Providing that training this evening is Kristen Ferguson. She graduated from Cal State University in Hayward in 1990 with a bachelor's degree in human biology with a minor in public health and public speaking. Following her undergraduate studies, Kristen spent 14 years working in the technology industry as a software sales representative and as a director of sales. In 2004, she was accepted to the nursing program Adelone College and came to work at Washington Hospital, working as a program coordinator for the Internal Medicine Hospitalist program. In 2006, she graduated from nursing school and began her nursing career as a staff nurse at Washington Hospital. Kristen has worked at various leadership roles over the next several years as a staff nurse, as a charge nurse, and as a bed management nurse. In 2011, she was selected to participate in a one-year administrative intern program, working under the leadership of the Chief Executive Officer and Associate Administrators. In 2012, Kristen graduated from UOP with a master's degree in nursing, with a focus in nursing leadership, and with a master's degree in healthcare administration. She became the Director of Risk Management in 2012, and in 2013 was promoted to Senior Director of Compliance and Risk Management. In 2014, she was promoted to Chief of Compliance. She is an active member of the Healthcare Compliance Association and the American Society of Healthcare Risk Management, and she holds a professional certification in healthcare compliance. With that, I'll turn the program over to Kristen.
Thank you, Nancy. And good evening. And I want to begin by saying congratulations to each of our board of directors. As Nancy stated, California state law requires that elected public officials receive ethics training every 2 years. So I'm back with you again tonight to conduct that education session with you. And it seems especially appropriate to be here with you this evening after the swearing in of your official duty. So again, congratulations. What I'll be doing is reviewing Assembly Bill 1234 with you, which gives an overview of concepts of law and ethics. And we're going to talk about how these ethics laws apply to you, our publicly elected board of directors. Our compliance to this regulation really begins with the hospital's Code of Professional Conduct. We have a very detailed code of conduct here at Washington Hospital, and all who work and who practice and who govern at Washington Hospital are required to adhere and to comply to our professional code, and the code also speaks directly to you as our board of directors. In addition to the training that we're going to be doing tonight, each member of the board of directors will also be required to complete a 2-hour web-based training on the subject matter of ethics. I know that's your favorite thing to do, but it is mandated and required according to the Assembly Bill 1234. Tonight, I'll just be giving you a quick highlighted overview of the concepts of the bill. It's also important to note that at Washington Hospital, we have many conversations as it relates to the subject matter of ethics. We have ongoing discussions, and we present information and presentations about the subject matter of ethics, as in this presentation that I'm presenting to you this evening. So the basis of all of this really is a set of basic ethical principles for public service officials, and they are really quite simple. They are fidelity to your mission, responsibility to the community that the public official serves, and the principles of fairness, loyalty, trustworthiness, and respect. From these principles become a set of ethics laws, and these laws can be quite complex and they can be very complicated. There are many of the laws, there are many facets of these laws, but the gist of it is they provide a minimum standard that each public official is indeed in their official role adhered to comply with. And it's important for you to remember that in your role as an elected public official, your first obligation is always going to be to the community that you are indeed serving. So I'm going to address all of this tonight based on 4 major categories of ethics laws, and they are laws related to personal gain, laws related to personal advantages or the concept of perks, government transparency laws, and laws related to fair processes. And the first issue is that of personal financial gain. And the underlying principle here is this is really about public service. And probably the most well-known issue is that of bribery. And there is actually a whole set of laws related to this subject matter alone. By definition, bribery is something offered or given to someone in a position of trust in an attempt to influence or persuade an official officer. It's important for you to note that it is a crime if you do solicit or if you receive any type of benefit in exchange for official actions in your role as a public official. And in relation to these specific laws, benefit is not just the idea of receiving some type of cash benefit. There are other considerations you need to think about. It could be a potential job, a special consideration such as a license or a permit or something else that somebody may want to get from you in your role as a public official. So a key issue related to the idea of personal financial gain is that of conflict of interest. And there is a whole fundamental principle as it relates to conflict of interest that actually comes from a California court case. And what's important for you to keep in mind is that public officials and designated employees must always exercise absolute loyalty and undivided allegiance to the best interest of the entity they serve and not themselves. So the concept of conflict of interest is embodied in the Political Reform Act, which was adopted in 1974. You also see ideas of conflict of interest outlined in the Fair Political Practices Commission regulations, which state there are 4 components of a conflict of interest, all which must be present actually in order for a conflict to exist. So the things that you need to consider are a financial interest. Is there a financial interest associated with the conflict? There has to be a conflict that's reasonably foreseeable. There has to be a material financial effect of the relationship, and it has to be distinguishable from its effects on the general public. So if everybody, the concept here is, so if everybody has the same opportunity, it probably is not distinguishable, and as a result, then it probably is not indeed a conflict of interest. And again, it's important to remember that all 4 components have to exist in order for a conflict to exist. The information here on this particular slide is especially helpful for you. It's important for you to be aware that there are 6 types of economic interests. So when you consider whether or not a conflict of interest may exist, these are the things you want to think about. You want to ask yourself if the matter involves someone that pays you an income. Does the matter involve property that you may own or lease? Does it involve your employer? You need to consider maybe some of your investments that you have. Does the matter involve someone that has given you a gift? Or does it even potentially involve your family's finances? And these may be things that you recognize because these are the categories that are actually reflected on the Form 700, which is the disclosure of economic interest that each board member and designated identified hospital employees are required to submit and complete and submit annually. So there are several regulations as they relate to conflict of interest that do compel impartial performance, and these regulations are a guide for you. They're to help to keep public officials free from bias. The regulations also require disclosure of certain financial holdings in writing. Again, this would be on the Form 700. So if you have any conflicts that you are aware of, you are mandated to declare them on the Form 700 each year when you submit that document, as well as when you are having discussions in your board meeting. If there is a conflict of interest that is identified during those discussions, you indeed then have to declare it, and then that conflict needs to be recorded in your meeting minutes. That's important for you to understand. The regulations also require disqualification and from things like discussions, deliberations, or voting on particular conflicted issues that would indeed prevent any type of conflict of interest from being present. And the idea or the belief here is that someone's presence alone can actually influence another person's decision making, so you need to keep this in mind. The regulations also require a conflict of interest code, which we do have in place here at Washington Hospital. Another important thing to consider or to think about is it's not actually the conflict of interest that could be the potential issue or the problem. It's indeed what the elected official does with acknowledging and disclosing that conflict, which could be the potential issue or the problem at hand. So in terms of best practices as it relates to personal financial gain, you want to be aware of these types of economic interests that I reviewed with you this evening, these 6 categories that we just discussed, and you need to consider whether or not any of these may trigger you to have to step aside or recuse yourself or disqualify yourself from discussions or potentially voting on a matter. And it's important to remember that you make all decisions with only the public's interest in mind, not based on your own personal interests or the interests of your family members or those who are close to you. The second category is known as the no perks laws, and the underlying principle here is that public servants should be treated like anyone else. So as a public servant, you should not be receiving any type of special benefits simply because of the office that you hold. So when you think about perks that others may give you, things like gifts, maybe travel or other types of honoraria, the considerations here are the need for having to report them on an economic disclosure. It's also important to remember that there are gift limits within a 1-year period. The possibility of having to disqualify yourself from a discussion or a voting process based on a gift you may have received from someone. You also have the option of declining a gift. You can return a gift. You can donate a gift to a cause or a charity that you've been given, and you can also reimburse the giver of the gift. A second category of perks that officials can give themselves is use of public resources, and you have to be really careful and think very carefully about this. So use of things such as telephone systems or computer systems or letterheads of a public entity, you are prohibited of using those things for your own personal or your own official gain. So these are things that you need to be mindful of. Under these same laws, you are also required to adhere and comply with expense reimbursement policies, and we indeed do have an expense reimbursement policy in place here at Washington Hospital. So best practice as it relates to perks, I encourage you to try to avoid anything that may be considered a perk, okay? And again, these laws are complicated. They can be very complex. And so if you have any questions about anything that may be appropriate or acceptable, I encourage you to just reach out and seek out counsel or guidance and get some questions answered for you on matters that you may be unclear about. There's several of us who can answer those questions for you and help you with those decisions that you need to make. The third category is governmental transparency laws that we're going to talk about. And the underlying principle here is the public trusts the process that it can see. So conversely, the public is not going to trust something that they are not privy to. So the need for transparency is critically important in the role that you play as a public official. And the recommendation here is to provide the public with the opportunity to participate and monitor the activities of a public entity or a public official. Regarding economic interest disclosure, this is a great vehicle indeed for fostering transparency, and this is a requirement of the Political Reform Act of 1974. Here again, we see the Statement of Economic Disclosures, the Form 700. So again, every elected official, so each one of our board members is required to complete that form and submit it when they take office, and then you are required to submit the form annually, and if any of your conflicts change, then they need to be declared in that document, and then you are required to submit the Form 700 when you leave office as well. Another issue in relation to governmental transparency laws is charitable fundraising disclosure. And so the public has the right to know about the types of funds that are being donated to a public official's favorite causes or charities, and the public is interested in that information, knowing where are these dollars going and how are these dollars being used, and they have that right to that information. So that's something that you want to keep in mind as well. As you are all aware, there's a law called the Brown Act, and this is the law that establishes our requirements for public meetings. And so the Brown Act requires that we have open meetings to assure that the public is informed about the decisions that you are making as a public official. Within the Brown Act, there are some permissible gatherings where the Board of Directors can meet outside of those public meetings at gatherings such as conferences or community meetings and social events. So you have the ability to do that. The Brown Act also provides the provision for closed board sessions as well. And this is all really based on the public's right to be able to participate and be heard. And this is why we have various requirements, such as the requirement for having to post a board meeting agenda for the public prior to the meeting. Under the Public Records Act, the public also has the right to access records from a public entity, and this gives them insight into the workings of that entity. But it's important also to remember that there are specific types of documents that are indeed exempt from these laws. And here at Washington Hospital, we do have a written policy in place, and the language in that policy is consistent with the language in the Public Records Act that we indeed adhere to. So best practice as it relates to governmental transparency, you always want to follow regulations carefully, and you probably always want to err on the side of openness and be transparent in your duties as a public official for Washington Hospital. Lastly, I want to talk briefly about what we call fair process laws, and the underlying principle here is everyone has the right to be treated fairly by a governmental process. And related to fair and unbiased decision-making, the requirement is that you exercise power that's free from personal bias and that your decisions be made and without the consideration of potentially an ability to see financial loss or financial gain. Also, in relation to these laws, it's important to think about that sometimes the process of recusing yourself or disqualifying yourself from a discussion or from a vote can oftentimes indeed resolve these various types of issues. Another part of the fair process laws is the doctrine of incompatible offices, and this is important for you to understand as well. This is based on the belief that there could be significant clash of duties or loyalties if a public official holds more than one office. So the penalty for this can be the forfeit of the first office. So if you are ever asked to participate in another official duty or capacity, it's just important to remember this and to remember that there are some requirements out there that you need to consider. Under these laws, this is where we also see competitive bidding requirements, and these requirements assure equal access and avoids the concepts of cronyism in granting public work at a public entity. The requirements also assure that the public is receiving the very best value for the money in supporting public entities, thus the requirement for having to publish bid notices for all work at a public entity as well. Another concept as it relates to fair practice laws is the concept or the idea of nepotism. And when it comes to decisions involving your family members, it's important to consider this and to consider anti-nepotism laws. These laws are required by the Political Reform Act, and they really are based on the idea that it can be extremely difficult to be fair and unbiased when you're dealing with your family members. So I want to remind you that in your role as a public official and a board member for Washington Hospital, that your loyalty always must lie to the entity first and not to the interests of your family members when you are making decisions in an official capacity. So best practices as they relate to fair process laws. You always want to consider all information on a subject in a fair and unbiased manner before making a decision in an official capacity. So just a few quick closing thoughts for you as we wrap up our education session this evening. As you know, public officials are stewards of the public's trust, and earning and holding that trust is based on very careful attention to the ethical principles and the public service ethics laws that I reviewed with you this evening. And it's also important to remember that ethics training for this board of directors is and always has been an ongoing process, and we will continue these discussions together. So I thank you for your time and your attention this evening. Any
Thank you,
questions?
Kristen. It's always informative. It's always nice to get reminded of all those principles. Thank you very much.
You're very welcome.
Any of the board members have questions?
All right, thank you.
Thank you again.
There's one more thing we want to show as part of our education session. There was a video that was developed that is about Washington Hospital Healthcare District's history. And I think, as most people know, we just celebrated our 60th birthday as a hospital, and I thought we might show the video tonight for our viewing public.
In the 1940s, as the Washington Township area grew, so did the concern for local access to health care. The closest medical facilities were 20 miles away, separated by 2-lane roads. The biggest concerns were for emergency medicine and maternity services. The need for a local hospital became evident in 1946, when the Silva Maternity Home in Niles, which had cared for expectant mothers in the community for 20 years, closed its doors.
Some older doctors up in Oakland, where I was a resident at Highland, Alameda County, they said, "Tom, you ought to go down to Centerville. It's going to explode down there with people." The babies were coming from everywhere, so it was a great experience.
The first public meeting regarding the hospital initiative took place in January of 1948 at a meeting of the Washington Township Business and Professional Women's Club in the cafeteria of Washington Union High School. At that time, a 50-bed hospital was proposed, with the hope that 2/3 of the cost would come through state and federal funding. After a June election, the Washington Township Hospital District was formed. The first board members were Manuel F. Silva, Alan Walton, Fred Melhaz, A.E. Alameda, and Lester S. Whitaker, who was elected president. When the government funds failed to materialize, the community took matters into its own hands. On November 4, 1952, Washington Township voters approved the sale of $1.25 million in bonds to finance the project. Soon, a 10-acre cauliflower field would be purchased from the Stivers family as the future home of the hospital. The location was on Santos Road, which later became Maury Avenue, and the hospital broke ground in March of 1955. Shortly thereafter, it became clear that a 50-bed hospital would not meet the needs of the surging population, and in 1956, the project was expanded to a 150-bed hospital. On November 24, 1958, the hospital opened its doors. Board members and a group of local doctors worked countless hours with help from the community to plan and build our hospital. These physicians became the hospital's first medical staff. Doctors Conrad E. Anderson, Merle Bueller, the first chief of staff, Lyle H. Bueller, Robert B. Fisher, E. C. Graw, E. M. Grimmer, Frank H. McMahon, John O'Connor, and Guy J. Romito.
I think the thing that made Washington a special place were the physicians that were here at the time when the hospital started. I think they were all a very conscientious and a very well-trained group, and were always available and treated their patients well. It was a good atmosphere to practice medicine.
It was started by the people who were farming and running businesses and were going to the churches and all that. They would talk about it. It wouldn't have happened without them.
From the very beginning, it wasn't just a hospital building that defined us. It was the dedicated men and women committed to the facility who made us a success. In fact, in 1955, 3 years before we opened our doors to patients, the Washington Hospital Service League was formed, holding their first meeting at the courthouse in Fremont. Josephine Walton was the first president, and along with Beth Grimmer and Pauline Alameda, worked to organize more than 100 volunteers who were dedicated to the success of their new community hospital. Their mission was simple: make a difference by helping others, and provide funds and volunteer support for the new district hospital. One of their first projects was the opening of a second-hand shop in Irvington called the Cheery Budget Shop.
The Cheery Budget Shop had all leftovers from people. Even the stores brought us things, and we had a lot of customers. And by the time the hospital opened, I think we had realized $13,000.
They took you on tours, they trained you, they staffed, and not just a few things. It was the lobby, the ER, gift shop. everything. It was a huge job. When people are in the hospital, there's a lot of anxiety. And if I can ease that or make someone smile, make their day, it gives me a lot more back than I'm giving. And that's what's kept me here. I like to be that person that somebody says, oh, I met this nice lady at the hospital and she helped me do something.
Well, I enjoy what I'm doing, and I hope I can continue to do it.
Washington Hospital was built 6 decades ago to serve a community of less than 20,000 people. To show how times have changed, in 1960, this letter from Washington Hospital's first manager, William Waddell, was sent to emergency services and nursing departments.
Effective February 24th, 1960, charges in the emergency room will be as follows. A $3 charge will be made when a patient is seen in the emergency room and non-expendable equipment or instruments are used. This will include tongue depressors and minor expendable equipment. The $3 charge will be used when a patient is seen in the emergency room in a sitting position and is examined for any reason. A $5 charge will be made when dressings and/or sutures are used to close a laceration not to exceed 2 inches and where the emergency room is not tied up in excess of half an hour. There will be a $10 charge for such cases as multiple lacerations and/or injuries where the operating room is used in excess of half an hour. When a patient is examined and is further admitted, there will be no charge for emergency service, but only when the patient falls in the category of the $3 charge as described above.
Today, we provide a full range of advanced, high-quality healthcare services for a population of more than 350,000 residents. From the beginning, we've truly been a community hospital in every sense of the word.
This hospital has always looked at the mission as what can it do for the community. And my experience has been that this is one of the rare hospitals, I mean rare, and I mean from the tip of Northern California to the Southern California, where the hospital's mission has always been patient first.
During the past 60 years, we have expanded our facilities and services to meet the increasing demand and changing requirements of our growing community. Our most recent facility is the Morris Hyman Critical Care Pavilion. It is designed specifically to meet the growing emergency and critical care needs of our healthcare district and to expand telemetry, intermediate, and oncology care.
The Critical Care Pavilion is a great example of the community coming together by passing a bond measure for themselves. It's what the community wanted. Washington Hospital said yes and really put that to fruition.
I think the community should really be proud of what Washington Hospital and the healthcare system has done for this community. What is the best way to have healthcare in this community so that people won't be traveling far away? They bring it to the people. We should be happy to be in Fremont because we have this state-of-the-art hospital.
As impressive as our continuing expansion has been, the Washington Hospital healthcare system is much more than buildings and facilities. Through the years, The physicians, staff, and volunteers who work here have always been the key to our ongoing growth and our achievements. Like Washington Hospital itself, our physicians, staff, and volunteers often remain part of our team for decades. That reflects an ongoing commitment to the patients and families we serve.
I love the people, the employees. I like helping them, especially the callers. If they need someone or they need some help, I like, giving them to whoever they need to talk to, and I love that. I love my job.
The commitment to Washington Hospital and to the community we serve weaves through our employees. Those with direct and indirect patient contact all serve our community.
Happy birthday, Washington Hospital.
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 Congratulations on serving our community for 60 years.
Congratulations on serving our community for 60 years.
Congratulations on 60 years of exemplary service to the community.
Congratulations on serving our community for 60 years.
Happy 60th anniversary to Washington Hospital.
Happy anniversary, Washington Hospital.
Happy anniversary.
Happy anniversary. Happy 60th, Washington Hospital.
Happy 60th, Washington Hospital.
Happy 60th, Washington Hospital.
Happy 60th, Washington Hospital.
Congratulations on serving our community for 60 years.
Wishing Washington Hospital great 60 years and 60th anniversary.
Happy birthday, Washington Hospital.
Congratulations on serving our community for 60 years.
Happy birthday, Washington Hospital. It is an honor to be part of an organization that for 60 years has worked to meet the healthcare needs of our community. Our patient-first ethic is ingrained in our history and will continue to be a part of our future.
60 years may seem like a long time, but to all of us at Washington Hospital, it feels like just the beginning.
That's a wonderful, wonderful feel-good video. Great the accomplishments of so many people that have preceded us. Wonderful, wonderful time to celebrate. We're ready at this point to move on to a consideration of minutes for the November 14th, 19th, 26th, and 28th of 2018.
So moved, Mr. President.
Second.
We have a motion and a second. Lee, would you take the roll, please?
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Danielson? Director Wallace?
Aye.
Thank you. Do we have any oral communications this evening?
We do not.
There are none. We'll now then move to our written communications and hear from Dr. Choi, our Chief of Staff.
Good evening. I have the credentialing items for tonight. Under appointments, we have 7 new candidates. The first is Jennifer Chan, MD, thoracic surgery. Brenda Castello, nurse practitioner. Lynn Wang, DDS, MD, surgery and oral and maxillofacial surgery. Mihan Nguyen, nurse practitioner. Yasuhiro Oki, medicine, hematology, oncology. Latha Sunil Kumar, medicine, and Nathan Van Dyke, medicine. Under temporary privileges, we have Dr. Jennifer Chan, Dr. Yasuhiro Oki, and Dr. Latha Sunil Kumar. Under the reappointments for 2-year, we have Dr. Elizabeth Addy, OBGYN, Dr. Amardeep Angrula, family medicine, Dr. Sumitra Chari, Medicine. Dr. Ajit Kumar Chikabalapur Narayana Swami, Medicine, Internal Medicine. Dr. Han Yuen Do, MD, OBGYN. Vinette Kambaj, DPM, Surgery, Podiatry. Dr. Young Kang, Surgery Urology. Dr. Sarah Kamlu, Podiatry. Dr. Basil Khoury, Internal Medicine Hospitalist. Dr. Manuel Lam, Internal Medicine Hospitalist. Dr. Roy Lin, Pediatrics. Dr. Deidre Liel, Obstetrics. Dr. Andrew Maxwell, Pediatric Cardiology. Dr. Bhaskari Pila, Pediatrics. Dr. Ranjana Sharma, Family Medicine. Dr. Megan Swan, Hospice and Palliative Medicine. Dr. Daniel Taylor, Internal Medicine. Dr. Anamali Veerapan, Gastroenterology. Dr. Huang Fo, Family Medicine. Dr. Albert Brooks, OBGYN. Dr. Edmundo Davila, Family Medicine. Dr. John Dearborn, Orthopedics. And Dr. John Mahegan, Vascular Surgery. The last 4 were one-year reappointments. Transfer staff category include Dr. Minesh Bhamani, Dr. Francisco Brunn, PA Stephanie Carnes, DPM Sarah Karamlu, Dr. Daniel Kennedy, Dr. Sanaz Kayan, Dr. Tarun Kumar, Dr. Brian Macbeth, PA Manal Mistry, Dr. Bhaskari Pila, DO Mark Penner, Dr. Marco Randazzo, Dr. Henry Sanchez, Dr. Payal Shah, NP Richard Quaitavis, and Dr. Sybil Sakuraya. Under completion of proctoring and advancement in staff category, we have Dr. Minesh Bhamani, Dr. Francisco Brunn, Dr. Tarun Kumar, Dr. Mark Loraldi, Dr. Brian Macbeth, D.O. Mark Penner, Dr. Marco Randazzo, NP Richard Quintevis, and Dr. Sybil Sakuraya. Under completion of proctoring prior to eligibility for advancement in staff category, we have perfusionist Amanda Best and Dr. William McNaught. Under deleting privilege requests, new privilege requests, we have Sarah Karamlu, DPM Podiatry, and under delete privilege requests, we have Edmundo Davila, Family Medicine. Under leave of absence, we have Dr. Carmen Akawili. Under resignations, we have Dr. Marcos Alvarez, Dr. D.O. Barbara Boyer, Dr. Mohammed Habuk, Dr. Jay Lee, Dr. Barry Shibuya, and Dr. Alpa Vora.
Thank you. Do we have a motion on the medical staff credentialing items? We have a motion, a second?
Second.
We have a motion and a second on those action items. Dee, would you take the roll, please?
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Eben.
Aye.
Director Danielson. Director Wallace.
Aye.
Thank you. That motion passes. We can now go to our Service League report from Jeannie. Anxious to hear how the jewelry sale went.
Oh, the jewelry sale. Big news, big news. Well, happy holidays, everybody, from the volunteers. We did have the jewelry sale last week, and it was probably one of our best ever. So we thank you all for your support, the staff. The community really came through, and everybody seemed like they had a great time. I think it was probably one of my most enjoyable because it was just so well done and so well received. So that went great. So I was happy to give that report. Also, just with the move into Morris Hyman, the volunteers are refining and defining our expanded role, trying to fine-tune so we can meet the needs. But that's ongoing, because there's just so much to learn, and we're trying to give the staff a chance to figure out their space before we get in there and try to make things better also. That's it. Oh, one more thing, I forgot. We're being introduced to a potential dog visitation program and to be brought here at Washington Hospital to really enhance the experience of our patients, to have a furry friend visit. So we just had a meeting and we're figuring it out how the volunteers can come alongside and make that happen.
Thank you, Jenny. I was curious about the jewelry sale because my wife was here twice and then she sent me back.
Yeah. Repeat customers are our favorite customers.
Thank you, Jeannie.
Thank you.
Dr. Choi, the medical staff report.
I'm happy to report that the medical staff membership has a grand total of 593, of which 352 are active. And most of us have gotten lost in the pavilion already and are learning our way.
Thank you. Thank you. We'll now have our hospital calendar. Nancy, if you could present that
Start
for
with
us.
the video, please.
Past health promotions and outreach events. On Thursday, November 15th, as part of the Women Empowering Women series, Dr. Victoria Leaphart, gynecologist, presented Keeping Your Brain Healthy. 10 people attended. On Friday, November 16th, as part of the Speakers Bureau, Dr. Victoria Leaphart presented Mindful Eating During the Holidays to the residents of Acacia Creek Assisted Living Facility. 37 people attended. On Wednesday, November 28th, Dr. Victoria Leaphart presented How to Sleep Your Way to Better Health. 23 people attended. On Friday, November 30th, Lori Roffelson, registered dietitian, presented Healthy, Happy Holiday Eating. Participants learned how to prepare delicious, healthier alternatives to the traditional favorites to enjoy during the holidays. Each attendee was invited to create a cookie mix gift or a mini apple pie to take home. 27 people attended. On Thursday, December 6th, as part of the Diabetes Matters program, Anna Mazet, registered dietitian, presented Latino Cuisine. 15 people attended. This presentation explored modifying traditional recipes to make them healthier without losing their distinctive flavors. Upcoming health promotions and community outreach events. On Saturday, January 12th, from 10 a.m. to 2 p.m., Lucy Hernandez, Community Outreach Manager, will provide blood pressure screenings along with health and nutrition information at the Health and Wellness Fair, co-hosted by Schilling Elementary School and Mexico Tortilla Factory and Deli in Newark. On Thursday, January 17th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leaphart will present Fit is the New Skinny. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. November's featured topic was Advanced Maternal Fetal Care, which highlighted Dr. Jacqueline Chu and the Prenatal Diagnostic Center, plus articles on our special care nursery and improving patient care with pediatric hospitalists. The Washington Hospital Healthcare Foundation Report. For the 23rd year, Washington Hospital Healthcare Foundation welcomed in the holiday season with the Trees of Angels celebrations. These tree lightings raised funds for hospice and palliative care in the Washington Township Healthcare District. The festivities began on Friday, November 23rd, when Washington Hospital was the presenting sponsor for the Niles Festival of Lights. Foundation trustee Gabby Bernardin and her husband Mark rode on the Washington Hospital float in the parade. On Monday, November 26th, Fremont Mayor Lily May lit the Angel Tree at the Bernardin Family McDonald's restaurant at the corner of I-680 and Mission Boulevard. 125 district residents joined the foundation for the occasion and were treated to seasonal music sung by the St. Joseph's School Children's Choir. On Thursday, November 29th, the foundation hosted a tree lighting at Washington West. Entertainment was provided by the Children's Choir from Canango Little Washington Township Daycare Center and the Tap Dancing Christmas Trees from Dance 10 Performing Arts Center. After the tree lighting, Santa and Mrs. Claus sat for pictures with the children. On Monday, December 3rd, the foundation partnered with the City of Newark to light the municipal holiday tree at Newark City Hall. Helen Kennedy, president of the foundation, made remarks, and the Cougar Choraleers from Newark Memorial High School sang for the crowd. Finally, on Wednesday, December 5th, the foundation joined with Union City and the Union City Chamber of Commerce to light a holiday tree at City Hall. Helen Kennedy emceed the event, and the James Logan High School jazz singers set a festive mood for attendees. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District Board members attended the Newark Chamber of Commerce Holiday Luncheon on December 6th, and the Masonic Homes of California Holiday Tree Lighting also on December 6th. Washington Hospital Employee Association, WHEA. The catastrophic wildfire in Butte County is the deadliest and most destructive fire in California history. The death toll from the Camp Fire has risen to more than 80, destroyed 14,000 residences, burned an area more than twice the size of San Francisco, and more than 45,000 people were evacuated. In response, WHEA collected funds and goods to assist our neighbors in Northern California. Janine Zayad, the president of WHEA, said, "Our hearts go out to our friends and neighbors who have been impacted by the wildfires devastating the communities. We're committed to helping as much as we can." In support of One Child, an East Bay agency for children, on Tuesday, December 11th, the Washington Hospital management staff donated hundreds of gifts, including bicycles, clothing, and toys, to Tri-City area families in need. The families were identified through One Child and East Bay Agency for Children. Founded by Bernie Dutra, One Child is a nonprofit organization dedicated to providing underserved children with new clothing, school supplies, and holiday gifts. Mrs. Dutra's passion to provide all children with holiday gifts and the basic necessities for success in school has allowed One Child to serve over 5,000 children to date. East Bay Agency for Children manages the Healthy Start program for Fremont and Newark Unified School Districts. Washington on Wheels, WOW Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic, WOW, is a mobile medical unit providing quality healthcare services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. Despite being out of commission for multiple days, during the month of November, WOW served community members at the Fremont Resource Center, Fremont Senior Center, and TCV Food Bank and Thrift Store in Fremont, Ruggieri Senior Center in Union City, and the Viola Blythe Community Services Center in Newark. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of November was 11. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's employment section was November's most viewed webpage with 29,353 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of November, Washington Hospital's cable channel 78 InHealth captured new programming, including 2 health and wellness programs titled How to Sleep Your Way to Better Health and Healthy Happy Holiday Eating, a caregiver series program called Caring for Someone with Dementia or Other Medical-Related Memory Loss, and the Diabetes Health Fair. In addition, InHealth aired a health and wellness program titled How to Stop Disease Before It Starts, a Diabetes Matters program called Filipino Food Made Healthy, and the November Board of Directors meeting. Additional events and announcements. November 24th marked the 60th anniversary of Washington Hospital. Over the years, while the buildings may have changed and service lines grown, what hasn't changed is our dedication to the members of our community and our patient-first ethic. On Wednesday, November 28th, the staff, physicians, and volunteers celebrated this occasion with specialty cupcakes, a beautiful anniversary cake, and other sweet treats. We are proud to serve this healthcare community. Awards and recognitions. Washington Hospital has been honored with the 2018 Achievement Award for meeting or surpassing the federal target aimed at reducing the state's low-risk first birth cesarean section rate by Smart Care California and a state healthcare coalition. A cesarean section includes all the risks involved with major surgery and should not be performed unless there are medical indications for the mother or child. The support of vaginal births, when indicated, comes with decreased risks to both the mother and child. To receive this award, a California hospital must have achieved a C-section rate of 23.9% or lower for low-risk first birth deliveries. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
And now I'd like to introduce to you Devinder Kaur. She's our certified phlebotomy technician from the clinical laboratory, and she's this month's Employee of the Month. She began her healthcare career working in nursing homes, and I think that experience showed her the power of caring for others. She's one of those exceptional people who believes that people who give are more blessed than those who receive. With this outlook, when she joined Washington Hospital's family in 2013, she was a perfect fit. She began as a nursing assistant, and after 6 months was transferred to the emergency department, where she worked as both an assistant and as an ER technician. She decided to return to school to become a certified phlebotomy technician, and she joined the lab in 2017. According to her supervisor, Rudy Aguilar, Devinder embodies the patient-first ethic with compassionate care that often includes the family members of patients. Knowing her task of drawing blood may cause physical pain, she strives first to make her patients comfortable, introducing herself and explaining the process. She's a mother of 2 boys. She's happy to work on the night shift, allowing her more time with her sons. Her coworkers appreciate her willingness to pitch in when needed, whether helping with patient orders or delivering specimens to the lab. One colleague describes Devinder as a welcoming presence. Devinder Kaur is an important part of the laboratory team and the Washington Hospital team, and we're very proud to have her work at our hospital.
Thank you, Nancy. We're now ready for our Lean Kaizen report. Nancy, if you could introduce that for us.
Yes, I will. We're going to have 3 members of our leadership team presenting tonight, and I'll introduce all 3 of them now. First is L.V. Bilar. She's a registered nurse with a bachelor's degree in nursing. She began her career at Washington Hospital in 1998 as a bedside nurse in ICU. She holds specialty certifications as a clinical nurse manager leader and critical care registered nurse. She's grown professionally in her 20 years here and is currently the nurse manager for the critical care and intermediate care units. Also presenting tonight is Jimmy Chang. He received his master's in nursing from Samuel Merritt University in Oakland, California. He joined Washington Hospital as a new grad in 2008, and he began his employment on 5 West. In addition to his role as a bedside nurse, Jimmy also functioned as a nursing and patient flow supervisor. Currently, Jimmy is the nurse manager for the medical oncology unit. Also speaking this evening is Alex O'Brien. She began her career at Washington Hospital in 2010 as a new grad and began her employment on 5 West. She received her master's in nursing in 2016 from Loyola University in New Orleans. Alex is currently the nurse manager for the telemetry and central surveillance units. Prior to taking this role, she was the assistant nurse manager on 5 West. So we'll begin our program now.
Thank you, Nancy. Good evening, everyone. I'm Elvie Ballar, and I am the manager for the critical care units. Earlier this year, we had several lean workshops to prepare ourselves for the transition to the Morris Hyman Critical Care Pavilion. Why was it necessary to do all these workshops? It was necessary to do the 5S so that we can identify the necessary equipment and supplies that we wanted to bring versus those that we thought was necessary to bring. 5S was also necessary in the old previous critical care units so that we can develop a standard way of how to keep the work area clean and organized. And we also wanted to train our staff on lean methodology. This is our A4 document. It is the document that guides us for the focus and the purpose, the target boundaries, and the scope of what we were to do. We wanted to focus on supplies and our equipment rooms. Here's the team touring our new home, the Morris Hyman Critical Care Pavilion. We needed to be in the Gemba so that we would know the workspace as we prepared for our workshops. Our team divided into 4 subgroups. We had the blue cabinet teams, the white procedure cart team, the alcove and equipment area team, and the hallway supply team. 5S is key to an organized workplace. It is the foundation of the lean methodology. 5S stands for sort, set in order, shine, standardize, and sustain. Here's our team in progress. We collaborated with each other. We assessed, we determined which appropriate locations, supplies, and equipment should be at. Another thing the team did was we decided to use a color coding system. It is a very good visual cue for staff. We categorize items by systems like wounds. Anything related to wounds would be color blue. Anything related to GI would be color brown, and so on. Our blue cabinet team went through 21 cabinets in the critical care unit. Here we were able to discover quite a bit of items that were not needed and not necessary. We emptied out a total of 9 cabinets, and then what we did was we ensured that nothing else were to come back into these cabinets. We sealed them off, as you can see the before and after pictures. A very important thing that the team learned was that we did not need to keep all the unnecessary supplies for just in case situation, as it caused a lot of waste of space and also a lot of waste when we got inventoried. The team collaborated with a lot of different departments and solicited their expertise. Here we are with the laundry service team, getting their advice on how much equipment, how much laundry we really needed for our patients so that it would be available just when we needed it for them. Another area that we did 5S on was the white procedure carts. As you can see in your picture over here, the before picture, it was difficult to tell which was which because they all looked the same. The cabinets and bins were the same. After the team did their 5S process of sorting, removing items that wasn't needed, doing the correct par leveling, and color coding the carts, you can see that the bins are easier to see. One would know exactly which bin to open when they needed the supply for the patients. Here is our equipment alcove. ICU has a lot of specialty equipment. However, this alcove, as you can see in our before picture, had no order into where we had placed the supplies. If I were to get the equipment that was against the back wall, it would be a little bit challenging as I would have to move everything out of the way. So after our 5S team are done, they develop a parking space for each of the equipment. And this really helped the team. There are pictures on the wall, which designated the actual parking space. And we also created a red zone for easy retrieval and return and access of the equipment. We did the same thing for the RT alcove area. We sorted and labeled the space, and as you can see in the after picture, it is much more easier to access the equipment that we needed. ICU had 6 hallway supply closets. Before, we had a lot of items that were not labeled. If they were labeled, you can barely read them because they were very small. So the team went ahead and did our 5S. We sorted each item, we labeled the areas, we par leveled it to the correct amount that we needed, and we also did the color coding system. Another thing that we did was do a photo, put a photo on the wall so that the team would have a reference of what it should look like. Red tagging is a system in the lean methodology in which every item that we removed, we put a red tag on it, and we also logged it in. Here you can see our red tag room with all the equipment and supplies that we had removed. Since then, these items have been repurposed to the departments that really truly needed it, or they also have been recirculated back to the units in terms of when they need it. And unfortunately, we did find some equipment that expired, so that we did have to discard that. In preparation for the Kanban card system, the team updated the par level list. The team had determined the right quantity of supplies that we needed in our supply area, so this list was updated. And here is a Kanban card. This Kanban card is a very good signaling system, which the materials management uses, so they know exactly when to replenish our supplies. Now, after our Kanban card setup, all our supplies, including the medication room, the supply room, the hallway supplies, everything had a set place. Everything had a reorder card. So that way, the staff had the item exactly when they need it, just when they need it. And more important, we had it available for the patient. The last thing our team did was to develop a operator standard work instruction sheet. We had to educate all of the staff in the units on how the Kanban system worked. And I'm happy to say that in our transition to the workshop, the staff have adapted well to the system. Now all our items have a space. We only brought what we needed. We have a very efficient replacement system with a Kanban card system. And our patients have what they need just in time, when they need it. Okay.
Thank you, Elvie. Hello, my name is Jimmy Chang. I'm the manager of medical oncology, and it's a privilege being here this evening. Lean and 5S is a valuable activity, something that 4 West, where we previously were located in the main tower, it was valuable in terms of making things more efficient and getting the right items to patients more quickly so that we could not delay treatment. It was also a valuable experience for ICU. What was challenging as we encountered the Morris-Hyman transition period is we wanted to bring some of the lean methodology and 5S principles, even though we didn't have the supplies on hand. So in August, we conducted a transition workshop, and it was held focusing on 5S activities on the 2nd and 3rd floors of Morris-Hyman. which is the site of our current critical care unit, intermediate care unit, medical oncology, and telemetry units. This workshop was critical to the move to preset a standard layout of items, supplies, and equipment for each unit so clinical staff would be able to locate essential items and equipment necessary to care for patients. On the slide is our A4, which is our guiding document for the week, and it indicates our purpose, target, and workshop boundaries. Here are some diagrams of both the second and third floors. This is our Gemba, and Gemba means where the work is being done. The third floor is divided into 3 units. We have a telemetry, medical oncology, and intermediate care units there, and there are 5 pods, each with nursing stations. 2 are dedicated to the telemetry unit, which has 28 beds. Another 2 are dedicated to medical oncology, which also has 28 beds. And lastly, there is a 12-bed intermediate care unit. On the second floor, there are 5 pods as well, and a total of 48 critical care beds on the second floor. So the first part of our activity to start the week was to go to the Gemba in the main tower, and the group that participated that week visited 4 West, 5 West, and critical care to look at the current state of that time and to get a sense of the supply and equipment areas to have a better understanding of the current condition and how they would supply and equip Morris Hyman Pavilion. We took a tour of the building at that time, and it was a great opportunity for staff to look at what was constructed and the space that was going to be occupied. The site of our new Gemba was larger and had a interesting layout. So to get a better sense of the space and future location for where equipment and supplies would eventually go, we gave them a tour. After the tours, 6 workshop groups were created to work on different areas, focusing on the nursing stations, the supply rooms, equipment locations, medication rooms, design for patient room layout, and the respiratory rooms. The first group worked on a nursing station, and here you see the 5S sorting discussion that is taking place. They identified the items that typically reside in a nursing station and defined the items and separated them by their needs. Next, the team set the items in order and looked at how items would fit in the unit and considered optimal placement for ease of access and retrieval. And here is the final product, which concluded the activity for the week. The team created a layout of the department and where the items would be placed in the nursing stations. Part of their activity included taking photos, labeling, and laminating them, and placing them in the appropriate areas to create a good documentation and record of how the units would be designed once licensure was coming close to fruition. The same activity took place on the other units on the third floor, and here is an example of the documentation recorded for the telemetry units. Work Group 2 focused on some of the supply room challenges, and this team was confronted with challenges as supply rooms varied from unit to unit, both in size and configuration. The storage racks varied, and the number of racks that were available provided a daunting challenge. Simply migrating the existing supply list from the current facility at that time to Morris Hyman wasn't feasible. So as a result, they started sorting. The first thing this team worked on was to ensure that they had the appropriate par lists. The team reviewed the existing supply and usage list and was able to redefine the supplies and quantities needed. The goal was to have the right amount of items appropriate for the shelving and space available while ensuring accessibility to not delay care for the patients. This was probably the most exciting activity for me to witness because as managers, both Alex and I, as well as Elvie, we thought it was going to be a very daunting challenge, but to see them engage in brainstorming activity and discuss what items they felt weren't necessary, and that was validated by the low volume of use on expense reports. It was good to see them just go through that process and also to identify the necessary items by the volume and expense reports, just confirmation. Using their refined list, they began to set the items in order. They determined the rack configurations, the bin requirement needs to house the supplies, and the best workflows that would be best for the clinicians as they enter and leave the supply rooms. And lastly, the team tested, confirmed their plans, and they drew the set layout on standard worksheets. This was eventually used by materials management in preparation for the rollout to all areas prior to our licensure and opening.
All right, we have a few more work groups to go here. So work group 3 focused on equipment. And they needed to consider the different pieces of equipment that were needed on each of the units, how frequently staff is going to use them, and how quickly we need to obtain them when we do have that need for patient care. The goal was to have the right piece of equipment readily available and the right location at the right time. Photos were placed in the units in the storage areas to indicate which equipment should be placed where. And this was posted along with a checkout sheet that included the destination room, the checkout time, and the name and extension of the person taking this piece of equipment. That way that staff will not be wasting time later trying to locate that one piece of equipment out on the unit. Here we have a layout for our equipment rooms, both on the second and third floor, indicating where each piece of equipment will be placed. Medication rooms were also a big challenge, just like our supply rooms, because our units in the existing tower had fairly large medication rooms, and the new space we were dealing with, it was smaller in some areas and very different in the way it was laid out with the upper and lower cabinets was something our staff wasn't used to. But again, like just to reiterate what Jimmy said, the staff just took this in stride and they looked at the lists of what needed to be stocked in the medication rooms and they took on the challenge and they did an amazing job. We also had work group 5 tackle the patient room layout. So looking at the furniture provided in each room and working, moving that furniture around to figure out what is the best layout for the patient and also for the staff to be able to be in that room providing care. The standard room arrangement was replicated for all of the patient rooms. Work group 6 focused on the respiratory rooms. So there is a main RT storage room and supply rooms on both the second and third floor for respiratory to store all their supplies. We also worked on the room readiness checklists. And these checklists were used by staff to make sure that each of these rooms was adequately prepared prior to opening day. So the staff reviewed the checklist and made sure that it covered all of the equipment and supplies that they would need. So we had a lot of accomplishments during this. This was a very short 3-day workshop. At first, we thought we would just tackle the layout of one pod in critical care, and we ended up accomplishing much more. We were able to standardize the nurses' stations, organize the supply rooms, and review our PAR levels. We identified parking locations for all of our equipment. We standardized the layout of the patient rooms. We worked on the med rooms and standardizing the supplies and equipment there, and then also reviewed the room readiness checklist. This group got a lot of work done in 3 days. And here is some of the improvement work that was implemented prior to the move to the pavilion. So all the supply carts, file cabinets, and shelves. We labeled drawers and cabinets. We set and configured the layout and finalized those readiness checklists. Here are photos of our 2 teams. And a big thank you to Nancy Farber and to the administration for continuing to support our lean work, and to Stephanie Williams for being the executive sponsor on these 2 workshops. And this really would not have been possible with all your support. Thank you.
Thank you.
I'd like to add something about what they did. They made the move into that building seamless for patients. And it seems like pretty ordinary work, only in its simplicity is enormous profundity. And we have a common language now that's spoken throughout the House that is interdisciplinary in nature. It is understood in materials management as well as it is understood in nursing. It is a common problem-solving methodology. It is a common language for our House. Lean is a very powerful tool that these 3 managers embraced it and used it to our best advantage is commendable. It certainly served our patients well. I'm very proud of all 3 of them.
Thank you. Very, very impressive work. Just looking at the slides looked like a lot of little things together and a lot of common work together. Very, very impressive. Thank you very much. We'll now move on to our quality report from Mary Boron.
Thank you. So it's that time of year again to be discussing influenza and the season that's coming upon us. Just starting off with a reminder about what the definition of is influenza. I think most people are used to hearing it referred to as the flu, and it's really a highly contagious viral respiratory illness that can last up to about 2 weeks from onset of symptoms to really completion. When the fatigue's gone, you've finally recovered, can be even up to about 2 weeks. Just to give you an idea of how much it impacts just over the United States every influenza season, there are 3.1 million days of hospitalization related to influenza and 31.4 million outpatient visits across the U.S. So pretty significant thing that we have to deal with in the hospital, and patients and all families are impacted by it. At this time of year, you sort of know someone who's got the flu or has just recovered from it. So getting into a little bit about how it spreads. One of the reasons why it ends up getting so prevalent is because it spreads so easily. It's the droplets when you sneeze. It's touching something or a part of your face after you sneeze, or an area that has a droplet that you can pick up and then move into a mucous membrane like your mouth or your nose. It can also spread and be infectious a little earlier before you recognize you have the symptoms. So if you've gotten influenza and the first couple of days you may not have the full-blown feelings of being in the part of having a high fever, a lot of sneezing and coughing and sore throat, still could be infectious at those times because that droplet can still spread and cause illness. And as I mentioned before, this is basically fevers, chills, sore throat, runny, stuffy nose, that typical really bad body ache and fatigue that we've all had. Complications that can arise from influenza typically are you may be able to get a secondary bacterial infection, such as pneumonia, neuromuscular complications, even cardiac complications. And of course, some people end up being hospitalized. And we do have mortality related to influenza, especially in patients that are chronically ill. So it's something we need to take seriously as it comes through the season. One of the best ways out there to prevent getting influenza is by getting the flu shot. It's administered by needle in your upper arm with the hopes of preventing what is the most prominent virus out there that year for influenza. So for our influenza season right now, that's referred to from 2018 to 2019, which again spreads from October to March. What the CDC has come up with is covering a total of 4 strains this year. That's the typical ones that they've done enough research to do some predictive analytics to state that it'll be typically something along the lines of the 2 strains of influenza A and B. And this includes H1N1. People, of course, have a lot of reminders about H1N1. You tend to say that, and people say, oh, it's H1N1, no, it's back, but this is what we've been seeing since H1N1, and we understand it a lot better now that it is truly an influenza. In the years of 2009 and 10, when this was considered there was a stage where it was a novel virus, we didn't have the evidence to support that. Now we know it spreads like any other flu. So if you hear H1N1, just influenza and treat it like the rest of them. Our Centers for Disease Controls gives a lot of continual recommendations on this. They're always working on making sure that their evidence and research is up to speed to do what we can to prevent the spread of influenza. And basically, they recommend that anybody get an annual flu vaccination from about the age of 6 months on. You can get the vaccination. There is a group of people that we really want to make sure get it. It's all healthy adults past the age of 6 months, but adults that are 65 years or older are at a higher risk for catching influenza, and also tend to be more at risk for having chronic conditions such as asthma or heart disease or some sort of immunocompromisation or even a form of cancer. Children also who have not developed their immunity quite well from the ages of 6 months to 8 years. Another group we really need to make sure is getting into their pediatricians and getting their influenza vaccine. And pregnant women. This was very much a risk factor group during the H1N1 virus in 2009-10. And so pregnancy is something we still continue to focus on, making sure that those women can get their flu shots. Obviously, there are certain contraindications to it. People have a history of Guillain-Barré, should not get the vaccination. That is always part of the screening process. There's a lot of questions related to that to make sure that those patients don't get it if they're contraindicated. I think we hear a lot about the influenza vaccination, and there's a lot of myths associated with it. There's a lot of inconsistent information out there. So when we give this annual report, we try to kind of remind everybody of what the current evidence shows and dispel the myths and kind of focus on the facts. And the first one is, does the flu vaccine work? You hear this all the time. This year the flu vaccine is, how effective is it? And it's actually a little bit more effective than I think a lot of us think. And what it basically remains down to is the flu vaccine is still the best way to prevent us from getting the flu. If you get your flu shot, your chances of getting, especially a serious form of the flu, are reduced by 40 to 60%. And in the world of any type of treatment, that's pretty good, especially for a virus that is changing every year. So it's important to remember that it does work. It's the best intervention we know to prevent it from developing in you. Do you need to get it every year? The answer is yes, because the vaccine is, as I stated before, they spend a lot of time researching the type of virus, and they can do predictive analytics and research to determine what they think is going to be the best combination for it, and that changes every year. So that's why we all have to get it every year. And getting the flu vaccine should be around the time of October. We like to see most people having their flu vaccination by that time. Although it is effective throughout the year, so if you've missed that window at this stage, there's still plenty of time to get it, and it will give you plenty of immunity in the time that you need it to be effective, because it typically will start to show immunity results within about 2 weeks of the injection. Another common myth or question that people ask is, can I get the flu if I get the vaccine? And I think some of this comes from the fact that when people get the flu shot, I'm going to say this has even happened to me. I've gotten the flu shot. I feel kind of tired the next day, or, the injection site, of course, is sore. I think, am I getting the flu? But really, that's the body's response to developing the immunity so that you don't get the full-blown flu. So it does not give you the flu. And one of the main reasons why we know it doesn't is because it's not a live virus in the shot. And so therefore it's pretty much impossible to get the flu from it when it's not a live vaccine. But as I mentioned before, some people do get some feelings of fatigue afterwards and general discomfort that are not actually the full-blown flu. So for our 2018 to 2019 flu season, as I mentioned, they try to update and predict the value of the strain so that we can make sure that we're giving the right one. And for this year, it's, A strain is of the flu is what we're focusing on. Again, the CDC has said again this year that they're not recommending the nasal spray. I remember even up to 9 or 10 years ago when I would take my daughters to the pediatrician and I wanted the nasal spray, right? Because I didn't want to sit through them having the injection. And they started to say right around that time, you can have it, but we're getting to the point where we're not really recommending it. Well, now when I go in, it is not recommended. And most of it is because they're not finding it to be as effective. So that's why you see a lot more a lot more all physicians actually stating that they don't recommend the nasal flu vaccine, and that's coming pretty strongly across in the evidence, especially from the CDC. You'll hear the screening questions prior to getting the flu vaccine, and it'll tend to ask about allergies with eggs, and those people that is contraindicated. They are not eligible to receive the flu vaccine. Getting a little bit more specifically in what we do here at Washington Hospital, all eligible patients who come into the hospital are screened for symptoms of influenza. We try to in fact, we're doing this 100% of the time. When patients are coming in to the ED and being triaged, we ask about respiratory symptoms and mask people who have active symptoms at the time of triage. And we do have our flu vaccine here at the clinic, available 7 days a week, so it's easy access for residents in the area, which I think is great. And the Alameda County that we are currently basically working with to make sure that we're meeting the right standards and regulations that the county has mandated include that we do a mandatory vaccination on 100% of our healthcare workers. And if your healthcare worker declines the vaccine, they can do that. They have to wear a mask during flu season while they're in patient care settings. We have a great employee health department here who works diligently. Even towards the end of the summer, they start preparing for this. They go throughout the hospital. They do blitzes, educations. They dispel myths. They bring the flu vaccine to places that are convenient for employees to get it, and as a result, we've had some great results with being able to get our employees vaccinated appropriately. Another area we're focusing on, of course, is preventative measures, making sure that we have what we call respiratory etiquette stations at every entrance and exit of the hospital. So that's where you can grab your tissues, your mask if you're sneezing, wash your hands. We have the Prel dispensers all over, especially in the Morris Hyman Pavilion right now. We've got a bunch of new ones up in all sorts of different locations. Main tower, they're everywhere. So there's a lot of access to hand hygiene tools that can prevent the spread. And we continue to do a regular evaluation of our results. We look at the results annually at the end of influenza season and say, okay, what could we do differently to improve? That's always the question at the end of the year. And we obviously continue to look at our quarterly evaluation of patient vaccinations. So as I said before, they are also screened, and if they need to get a vaccine while they're in here, we want to make sure that we can give it to them, especially if they don't have a primary care doctor, or this may be their only interaction with the healthcare system while they're here acutely ill. And so it's a great opportunity to get in, educate them, and get them that shot prior to going. This little pink sticker here, this is our 2018 to 2019 sticker. So this indicates that if you're walking around and you see somebody with this badge, they've had their flu vaccination. That color changes every year, and it kind of like helps us keep transparent with who's had it, and we monitor that closely. On a national level, there are many groups that really look closely at this. Joint Commission is very focused on this, along with CMS, and they have required us since January 1st of 2012 to submit our data on what we're doing. Are we making sure that our employees are vaccinated? Are we making sure that all patients who are eligible got their vaccine, and if not, why? Those are submitted along with the Alameda County data that's submitted, and it goes as far as the CDC. The CDC can tell who was vaccinated in this hospital, what discipline was vaccinated, and they can do the and look at the percentages. And that is what you're doing. Seeing here first is the inpatient influenza immunization. The flu season 2017 to 2018 that was complete last year, we had 97% of the patients who were eligible did get the influenza vaccine, which is great for the patients that were eligible for it. That's well over the 93 national rate. Like I said, our healthcare personnel are another big focus, and you can see from looking in here right up to flu season 2017 to 2018, we were able to reach 92% of our employees were get vaccinated, with only about 8 declining. Now, 100% of them were offered the vaccine, and there was some interaction with that staff to say, you either are going to get your vaccine because you've agreed to it and consented to it, you don't have any contraindications, or we need you to sign a declination and give us a reason why. Because that data is kind of interesting, and if it's contraindication to your health, of course, that makes it simple. One of the questions that's on there is, are you afraid of needles? And actually, no, that's one of the answers. Sometimes people would rather wear a mask than take an injection. So it's interesting, though, that we've been able to get 92% is even pretty good success for that. Then as far as members of the community, or even what can you do, even after getting your flu shot, and just basic things in day-to-day that you should be practicing to avoid getting sick during flu season is, of course, like I said, get your shot, but really focusing on good hand hygiene. I mean, hand hygiene is the single most effective way to prevent the spread of any infection, especially this. Because even if you've been exposed to the droplet and you wash your hands frequently and at all the appropriate times, then when you're touching your face or anything, you're far less likely to get that droplet ingested into your body. Cover your mouth while sneezing and washing your hands. I think, a lot of us grew up sneezing and covering it like this. Those days are gone. They want you coughing into your elbow, because why put it on your hands when that increases the spread, right? So we've done a lot of education in children's classrooms and gone around, and it's interesting to see that generation pretty much sneezes like this now. So I think we're going to see some better compliance with that as the years go on. Another reminder is, when you do visit the doctor, do not expect to leave with antibiotics unless you have a bacterial infection that is something like pneumonia that's morphed after your influenza. It is a viral infection. Antibiotics do not work to combat it. And again, always to remember to consider looking at our urgent care and looking at the option of coming in there from any time from 8 a.m. to 8 p.m. And the walk-in flu shot hours are Monday through Friday, 11 a.m. to 4 p.m., and we have weekend hours, 12 to 4. No appointment is necessary. There are discounts available, and this is actually covered by Medicare Part B. So, one of the things that I think in general the government has done to improve the access to influenza vaccines is you can have them at a very cheap cost or maybe even no cost in a lot of areas if you meet the certain criteria, which is good. It's better access to that care for those patients. And again, for patients who have the symptoms of the flu, as I said, it can go into a very severe format, especially in people who are chronically ill. So if you're starting to have really bad fever, coughing symptoms, and you're chronically ill, and you're not able to get out of that slump, the best thing to do to go is to urgent care or to the ED so that you can catch it before it progresses any further. And that's it.
Thank you, Mary.
No problem. Thank you.
Let's hope none of us get it.
I know. It hasn't hit us yet. It hasn't been too bad so far this season for us, knock on wood.
That was my question as to whether it's ramping up at all or.
Yeah. So CDC gives us a really nice graph every week where you can see it across the United States and where it is. And no, where it's not quite here yet. For example, we've had many weeks recently. We had 0 patients in the hospital with droplet, had 1 this week, but in general, the surge hasn't hit us, which was great relief during the move because we didn't want to be in the middle of that during. So we're prepared now and ready to go.
Thank you again. We'll now have our finance report from Chris Henry.
Good evening. Tonight we'll be looking at the operational and financial results for Washington Hospital for the month of October. Average daily census in October came in 16.1 below budget at 144. We saw 949 admissions for the month. We'd expected 1,057. Patient days for the month likewise came in lower than budget at 4,463. We had expected 4,964. In our outpatient observation equivalent days for the month actually came in above budget by 43 at 184. Our average length of stay based on discharges in the month came in slightly below budget at 4.61 days. We'd expected 4.7. Looking at utilization case mix index for the month, this is the indicator of the severity of the cases we saw. For October came in at 1.453, a little bit less than the budgeted number of 1.476. Deliveries came in 14 below budget at 136. Surgical cases, however, were 44 above budget at 402. That included our joint replacement cases that were 15 above the budget at 154. Neurosurgical cases that came in pretty close to budget at 31, just 1 off of what we expected. Cardiac surgical cases for the month came in 6 below budget at 5. Cath lab procedures, likewise for the month, were 88 above the budget at 427. In October, we saw 7,945 outpatient visits, about 124 higher than we expected. And the emergency room continued to be lower than our expectations, but still busy at 4,047 visits for October. Quick look at the cath lab activity for the month. Cardiac activity made up 43% of the activity, followed by peripheral vascular procedures that were 37% of the activity, and then non-vascular interventional radiology procedures came in at 16%. Quick look at our productivity. Productive FTEs for the month were 50.7 below the budget at 1,235.1. We had 160.2 non-productive FTEs in October, giving us total FTEs that came in at 56.7 below budget at 1,395.3. Our full-time equivalents per adjusted occupied bed came in about pretty close to budget, a little bit less, at 6.57, so looked like we were staffed appropriately for the level of activity going on in the hospital. Now we'll jump into our financials, and as always, we'll look at our Governmental Accounting Standards Board presentation. This is the presentation we're required to use for our audited financials. Total patient revenue for the month came in $945,000 above the budget at $171,065,000. Our deductions, our write-offs for contractuals and bad debt came in slightly above the budget at 77.89%. Quick look at the breakout there. Actually, our contractual write-offs came in slightly favorably as a percentage of gross revenue, but as we've seen all year, that provision for bad debt and charity continues to inch up on an upward trend. I don't see any end in sight for that. I think we're to continue to see that for the foreseeable future. So we ended up with total deductions just slightly above the budget at 77.89%. So we ended up the month with actually net operating revenue about 233 below budget, 233,000 below budget at $38,279,000. And again, that's that provision for bad debt and charity kind of tipping us over the edge there. Operating expenses for the month actually pretty favorable, about $1.7 million below the budget at $37,209,000. We had several drivers there. With our lower FTEs, we saw salaries and wages lower than budget by $486,000. Benefits for the month actually were $753,000 lower than budget. That was driven by our health and welfare claims were pretty low in the month, about $457,000 below the budget. And as we discussed last month, the benefit from the actuarial calculation that came on our post-retirement benefits contributed about $225,000 to that variance. Supplies for the month came in a little bit over budget, about $395,000. That was driven in the by pharmaceuticals, cardio and neuro supplies, and prosthetics. Purchase services for the month were about $140,000 over budget. That was driven by repairs and maintenance in the hospital. I think a lot of that had to do with the flooring work that was being done preparing for the new building. And then depreciation for the month, we actually had expected to start depreciating the pavilion in October, but because of the delays in state licensure, that's not going to start until November. So depreciation was $984,000 below budget, giving us, rounding out that $1.7 million variance. So we ended October with an operating bottom line of a little over $1 million, almost $1.5 million above budget. We had actually expected a $410,000 loss for the month. Non-operating income came in $73,000 below budget at $611,000. That included a $149,000 unrealized loss in our investments, giving us a total bottom line from a GASB perspective of almost $1.7 million. And we had expected $274,000 in the month. So pretty good result for October. Take a quick run through the Financial Accounting Standards Board presentation. This is how Wall Street would adjust our GASB financials when they're looking at them. The big change here is really related to interest expense. GASB looks at that as a non-operating expense. FASB looks at it as an operating expense, so we reclass $433,000 up into the operating expenses, and we end up with an operating bottom line from a FASB perspective, about $1.5 million above budget at $917,000. We also factor out our general obligation bond, debt service collections of tax revenue, and that unrealized loss on our investments to adjust our non-operating income actually to a loss of $246,000 from a FASB perspective, and a total bottom line of $1,566,000, better than budget at $671,000. So, are there any questions on October? Nope.
Nice.
Okay.
Now we can move on to
The
November.
depreciation month,
Yes.
November.
Now it hits.
We had gross revenue of $169.2 million. Was below budget by $4.4 million, but above November a year ago by $2.9 million. Our inpatient gross revenue of $118.5 million was below budget by $14.6 million. Our outpatient gross revenue of $50.7 million was above budget by $10.2 million. And it was above budget compared to November a year ago. The shift from inpatient to outpatient is primarily due to the CMS mandate to move joint replacement patients from the inpatient setting to the outpatient setting. The major drivers of revenue variance were surgical service cases, which came in above budget by 18 cases, or a 4.7% positive variance. That drove our surgical services revenue $1.6 million above budget. The emergency room visits were below budget by 250 visits, and that drove our ER revenue down by $813,000. Now, I was a bit concerned because we'd been told we would have this big burst of visitors in our ER because of the new building. But I asked Chris to check with all the other hospitals. They're all down too right now. And I think a lot of it has to do with the flu hasn't hit yet. So we'll see what happens. The inpatient days were below budget by 579, and that drove our room and board revenue down by $3.4 million. The lower level of inpatient activity drove ancillary service revenue below budget by $1.8 million. In terms of key census statistics, our average length of stay of 4.48 was below budget. We had budgeted our length of stay at 4.69. The average length of stay was slightly longer, though, when compared to November a year ago. Outpatient observation days were 18 above budget at 147 days. Average daily census of 151.4 was also below budget. We had budgeted 170.7. In terms of our admissions trends, we had 103 fewer than we had planned. Admissions came in at 990. They were also below November a year ago. The major drivers of admission variance are again the shift in joint replacements to the outpatient setting. That impacted our admissions by 58 cases. Deliveries also were below budget by 30, and this is another number I asked Chris to check with the other hospitals. Their deliveries are down too. Neurosurgical admissions were below budget by 6 cases. Cardiac surgical admissions were below budget by 5. In terms of patient day trends, we had 4,542 patient days. It came in below budget by 579. The major drivers of lower patient days, the shift of joint replacements to the outpatient setting. Delivery cases being lower than expected, and inpatient cardiac and neurosurgical cases being lower than expected. But again, the biggest single driver of the variance is the mandate to move joint replacement cases to the outpatient setting. The surgical cases in November came in 402 cases above budget. No, they were numbered 402. They were above budget by 18. Sorry, I did that wrong. They were also above budget above our experience November a year ago. The inpatient surgeries were 68, below budget at 243. The outpatient surgeries were 86 above budget at 159. The increase in outpatient surgeries was outpatient general surgical procedures being above budget by 32, and the joint replacement cases shifting from inpatient to outpatient because of Medicare requirements. Surgical activity, our general surgical procedures were above budget by 33. Joint replacement surgeries were below budget by 3. Cardiac surgical procedures were below budget by 5. Neurosurgical procedures were below budget by 7. In the cath lab, we had 343 cases, 41 above the budget. Inpatient cath lab procedures were above budget by 34. Outpatient cath lab procedures were above budget by 7. In terms of peripheral vascular activity in the cath lab, they also came in above budget by 30. Cardiac procedures were above budget by 19. The neurointerventional radiology procedures were above budget by 5. The non-vascular interventional radiology procedures were below budget by 13. Deliveries in November numbered 120, and they were below budget by 30. In terms of our emergency, non-emergency outpatient visits, we had 7,123, and they were below budget by 168 visits. Our rehab visits were above budget by 53. Our respiratory therapy visits were below budget by 72, and our lab visits were below budget by 143. In our ER, we had 4,050 visits, and we were below budget by 250 visits. But we were busier by 19 visits than a year ago. Productivity indicators for November include productive FTEs coming in below budget by 36.8 FTEs. Non-productive FTEs were below budget as well by 24.3. So total FTEs of 1,444.3 were below budget by 61.1. Total productive FTEs per adjusted occupied bed of 6.02 were very close to our budget of 6.01. So our total FTEs per adjusted occupied bed of 6.68 were slightly below our budget, which was 6.79. Other operational statistics include our outpatient surgery center volume. They had 521 cases in November. These constituted 31 cases above budget. Clinic visits of 3,392 were below budget by 173. Washington Urgent Care had negative 103. Nakamura, negative 51. Newark Clinic, positive 45. We have a new physician working in that clinic, and it is really working well.
Very nice person.
Yeah.
The other day.
Did you like her?
Yeah.
Yeah, Dr. Stoll, I think, is going to make a great success of that clinic. It's a good model for reinvigorating the others. Now, the Warm Springs Clinic was down by 41 visits, and the Ohlone Clinic down by 23. In terms of our payer mix, government-sponsored patient revenue made up 71% of our total gross revenue, and that was slightly below the budget of 71.5%. HMO revenue was 2.4% of gross revenue, which was also below budget. PPO revenue was 23.6% of gross revenue, and that came in above budget. Private pay revenue was 3% of gross revenue. We had budgeted 2.2, and that very definitely reflects the trend in unsponsored patients. This is a time now in which the penalties for not being part of an insurance program have been relieved, and a lot of people have allowed their insurance to lapse. They're not going to be penalized. Key financial statistics. Days cash on hand for November ended at 191 days, down 3 days from last month. Days of gross revenue and accounts receivable were 51, which is absolutely stellar performance by our finance division and deserves recognition. There were $858,666 in charity care applications pending or approved for November. So you can see we're heading towards $1 million, and it won't be long before it's more than $1 million, and we'll be heading for $2 million. We're going to go back to the old trends in this.
Thank you, Nancy. I had just one question. I've noticed that the outpatient observation days are trending up. Is there for a long time, we were staying below budget on those items.
We're looking at that. I think some of it has to do with physicians not wanting to admit quite so quickly. We are turning these patients around. The length of stay are shorter, so that 180 some odd days is made up of more patients than it used to be. They're not staying in observation 1 or 2 or 3 days. It's just one of those trends that's moving up. We're looking into exactly why, but I think it has to do with folks not wanting to admit quite so quickly.
Okay.
Yeah.
Thank you. We now have an action item to consider. That is item number B. Dr. Nicholson.
Mr. President, I move for adoption of resolution number 1192, which is the Memorandum of Understanding between Washington Hospital and Teamsters Local 856, a recognized majority representative under the terms of Board Resolution 331A, effective December 12, 2018.
Have a second on that?
Second.
Motion and a second. Nancy, could you
tell you a little bit about what's in it?
Yeah, be nice to know.
We concluded the contract negotiations on Monday, October 8th, and the members voted to ratify the settlement terms on November 17th, so it has been ratified by the membership. Local 856 consists primarily of our clerical workers and is made up of 26 classifications for a total of 93 regular employees and approximately 34 per diems. I propose that the directors approve this memorandum of understanding. It is a 3-year contract. It runs September 1st, 2018 through August 31st of 2021. It provides for a wage increase over the course of that term. For the first contract year, all employees will receive a total of 2% across the board increases to base wage rates to be paid at 1% every 6 months. For the second contract year, the employees will receive a 2% across the board increase, also to be paid at 1% every 6 months. For the third contract year, the employees will receive a total of 3% across the board increases to be paid at 1.5% every 6 months. We used outside compensation specialists to provide us with an analysis of where we stood in the market. The board's policy is to meet the market. We had one classification, our coders, that was substantially below market. And that is something we are going to correct with a one-time 9% across the board increase for the first year of the contract for that specific group. This group is composed of 6 employees, but it straightens that out and certainly will help us with recruitment. So that's, in a nutshell, what we're proposing. It's my recommendation to the board that they adopt this memorandum.
Thank you. Dee, if you'd call the vote.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Wallace?
Aye.
Director Epen?
Aye.
Director Danielson?
Thank you, Dee. That concludes our agenda for the open session tonight. We'll now adjourn to a closed session. At this point, will we reconvene to an open session? We announce that no reportable actions were taken in the closed session. There being no further business this evening, this meeting is adjourned.